So we're now going to go through rapid sequence intubation with Steve here. So we've made the decision that Steve requires intubation. Now, rapid sequence intubation is the sequential administration of an induction agent and then a neuromuscular blocking agent to facilitate endotracheal intubation. Now, this is a very high-risk intervention that we do pre-hospitally, and you've got to take great care in whilst doing this, particularly with the drugs that you use. And intubation itself is a skill. You can get quite a number of complications with it. Now, indications for an RSI include failure of airway patency, failure to protect the airway, failure of ventilation and oxygenation attempts. It's anticipated that in the clinical course of the patient that RSI would be warranted, and it's also for humanitarian reasons, in extreme pain, a lot of burns and similar situations to that. Other indications may include traumatic brain injuries, GCS of lower than 10, hypoxic brain injuries, post-hangings, suspected airway burns, so things that may not be quite obvious on the out at the moment, but you've got a high suspicion that they do have airway burns, and that airway seriously does need protecting before it starts to swell. Severe hyperthermia, and if you've got a prolonged transport time of usually around 30 minutes plus with a quite critically unwell patient that you don't think you're going to be able to manage that airway for that long without a secure intubation. So one of the most important things that we need to do with this intubation is to make sure that we have all of our equipment ready, cross-checked and close at hand. So we have our PPE that I'm going to put on shortly, goggles. Got to make sure that you have a working laryngoscope and that the light has been tested. You also have a backup handle, which I do in the kit just behind the computer here. You want to make sure that your circuit is ready to be attached. So we have a BVM, a gooseneck, a CO2 monitor, as well as a bacterial filter to make sure that the monitor doesn't get soiled at all. We have our size 7 ET tube, as well as a 6.5 just behind the computer once again. We have our bougie, and we also have an introducer if we decide to use that method. We have our 10ml syringe already attached to the tube. We have our medications. For the sake of this RSI, we're going to be using fentanyl and midazolam, as well as succinylcholine as our induction and paralytic agents. We've got some pre-sized and checked already OPAs already in situ for this patient. We have 2 sized NPAs ready to be used as fallback plans, as well as iGel LMA that has been pre-sized, selected, and made sure we're working. We've also got our bag valve mask here ready to go in case we do need to bag this patient if we fail with intubation. We've got bilateral intravenous access, our SATS probe, heart monitor, BP cuff. They're all monitoring everything that we need to at the moment, and we're ready to get started on this induction. So the actual procedure for the intubation, first thing we're going to do is we're going to brief the team of all of our plans. So plan A is that we're going to do a direct view laryngoscopy. Plan B is, if that fails, we're going to use a video laryngoscope and video laryngoscopy. Plan C is fall back to iGel or LMA, and then if necessary, plan D will fall back to basic airways, OPAs and NPAs. So we've prepared the patients, we've got them in an optimal position for intubation. We've assessed how difficult this airway is going to be, and we're currently pre-oxygenating them with high-flow nasal prongs, and if they're currently breathing for themselves, then we can just put them on a non-rebreather, or if necessary, we'll be bagging this patient at the moment. Through one of the lines, we've also got some saline running, 10 mils a kilo, to make sure that we've got an adequate circulating volume, particularly with the side effects of the medications we can use. We don't want any hypotension, and we don't want any vagal stimulation causing any bradycardia or hypotension when we intubate either. And it's this point that we're going to go forward and complete the RSI challenge response checklist. Here's one that I have prepared earlier. So airway operator, that is myself, Michael. Drugs, that is going to be Tassie. External laryngeal manipulation, if necessary, that's going to be Bob. And C-spine and Mills is not required for this patient. Airway assessment has been completed and it is not predicted to be difficult. Position is optimized. Pre-oxygenation is underway. We have IV fluids running, that is correct. Equipment, we have our BVM, gooseneck, and our SATS probe, CO2 monitor, end-tidal CO2. I have all our rescue airways sized up. Bougie is burr, laryngoscope is tested, and we have a backup. We have ETT and the next smaller size ready. We have a suction ready to go. Surgical airway kit, our cricothyrotomy kit, is just at the end of the bed there. We have oxygen, plenty. We have 2 cylinders ready for this, and we're not using a ventilator for this patient. ECG monitoring is on, SATS probe is on, BP is cycling, and end-tidal is connected into our circuit. Our pre-medication drugs are not required. Now, our induction agent is going to be fentanyl and midazolam. Paralysis is going to be suxamethonium, and our post-intubation sedation we're going to use is morphine and midazolam. So plan A, B, C, and D have all been discussed. Our failed airway plan is our surgical airway kits, and at this point I'll seek any feedback from anyone that's helping with this assessment intubation to give me any feedback if they think things might go wrong or any suggestions that they may have at the moment. So it's now time to actually intubate Steve. What we want to make sure is that we do everything possible to ensure a first pass intubation. Position is optimal, checklist has been completed, and we're now ready to complete our RSI. We need to administer our induction agent, so in this case we have our fentanyl and midazolam. That's going to be administered. Once this has been administered, we're going to wait between 60 to 120 seconds for any adverse effects and to make sure that we've got the desired effect. Once that time has passed and there's been no issues, we're then going to administer our paralytic agent, our suxamethonium. So we're going to administer this to Steve and then spend the next 60 to 120 seconds ensuring that there's no adverse effects and that we've got an adequate loss of muscle tone. He's nice and paralysed, and we're now ready to insert the ET tube. So I'm going to remove the airway adjuncts that we've had in situ during this period. Get my working laryngoscope. We're going to pass the laryngoscope down the right hand side of the mouth, sweeping the tongue from right to left. Now whilst we're in this good position, we can have a good suction. Anything that is soiling the airway, suctioning on the way out. Now I'm going to pick up my bougie. I'm going to pass the bougie down. Bougie sighted to pass through the cords. Can I have my tube loaded onto the bougie, please? So maintaining sight of the cords. Thank you. I have the tube. Pushing the tube down the bougie. Tube through the cords. Fantastic. Tube bougie out, please. Thank you. Cuff up, please. Thank you very much. And we'll now remove the laryngoscope and attach our circuit. A few breaths. Making sure good rise and fall of the chest. And once we've got this, obviously we'll make sure that our ETCO2 monitor is working. It's now time to tie in the tube. Whilst I'm doing this, I can have someone preparing my post-intubation sedation of morphine and midazolam. We'll be inserting bite block. And we're confirming correct placement of the tube with auscultation over both lung fields and the epigastrium, making sure that the epigastrium is silent. And once we have tied in, we are 22 at the lips, and we have good rise and fall. And now that we've successfully intubated Steve, we're going to have a quick talk about ensuring that we watch out for any complications that may result from this. If we've gone down the right stem of the main bronchus and we could only be ventilating on the one side, it could be resulting in hypoxia. We also want to make sure that we haven't made this decision too rash. We want to make sure that the decision was well made. Precautions that need to be made are if the time to intubation at hospital versus time to intubate at scene. In general, if there's less than a 10-minute transport time, then you should be quite comfortable to handle that airway, and the RSI can be performed in a controlled hospital environment. If there's a poor baseline of neurological functioning for the patient or major comorbidities, then perhaps an RSI isn't quite the best idea. And in general, anyone suffering from severe hypothermia should just receive basic OA management. These patients require warming slowly in hospital. And complications following the intubation, dislodgements, like I said, down the right stem of the main bronchus, trauma to the airway during laryngoscopy or insertion, and bradycardia as you stimulate that vagal nerve on entrance. Now that we've covered all that, we'll move on to a discussion about end-tidal CO2. So working for New South Wales Ambulance, we have access to the EMA capnographs. Now to insert the EMA to the capnograph, you've got to use the adult. There's also a pediatric size of the tube. Clicks in, this fits into your circuit when you're ventilating a patient. Turn the EMA on. And now I'm going to demonstrate for you using my own breath how there's a reading on this. Now, as you can see, there's a nice waveform to the capnography there, and we'll go into a bit more about what each stage of those mean just now. So end-tidal carbon dioxide waveform capnography, quite common presentation is here in front of you. It's the continuous measurement of exhaled carbon dioxide. It's displayed graphically as a capnogram or as a waveform that represents the amount of CO2 present throughout the respiratory cycle. It's used to assess the efficacy of CPR, to monitor pathophysiological processes, and to potentially predict ROSC and ensure that how the patient is moving forwards post-ROSC. Now, this form right here, we have our baseline at the bottom as phase 1. Phase 2, we have the expiratory upstroke. So this is the point at which you begin to expire. You have a sudden spike in CO2. CO2 only comes from the point at which gas exchange occurs. So the main breath that comes from the bronchus that doesn't undergo gas exchange is the bit that comes out first, and then of course as you get to the top here, your alveolar plateau. It's when the breath that has undergone gas exchange throughout your alveoli is being expired, and the point at the beta angle is the measured end-tidal CO2. This is the most CO2 that was expired throughout that breath. Then obviously as you start to inspire again, your CO2 takes a marked drop as you're not producing any more CO2. Now, some of the common presentations that we can come across are ones such as you can see here. So in patients that have asthma and COPD, they find it quite difficult to expire that breath with the structure collapse. It's difficult for them to expire air. So you have almost this shark fin appearance here as they force the breath out, and then obviously inspiration and drop back down to the baseline. You'll notice that the end-tidal CO2 is quite often higher than the 35 to 45 range that we do go for. Patients that are hypoventilating will have a CO2 that is higher than the 35 to 45 baseline that we're looking for. They'll also have very long waveforms as they come across, and conversely, hyperventilation will be below, as the gas exchange doesn't have enough time to effectively transfer that oxygen and carbon dioxide through the lungs, and you have the really short waveforms. Another one that can happen quite commonly, which I'm going to just demonstrate for you here, is if we have the first few breaths of post-intubation, and you may notice that you get a good CO2 reading at first, and the next one's not quite as good, and the third one's getting worse. That's a pretty good indicator that you may have intubated the esophagus and that you're currently blowing up the patient's stomach.